Hey guys, welcome to our YouTube channel. This is the Wits Students Physician Society. My name is Kiara, and today we're filming one of the videos in our new series called the Specialties videos. Today we will be interviewing the rheumatologist Dr. Ziki. I'm joined with Dr. Ziki, and we've already introduced ourselves to each other, so we'll just jump right into the questions. So what is rheumatology?
Rheumatology is a subspecialty in internal medicine where one spends their life seeing patients with autoimmune diseases, and these diseases are either systemic and they generally affect the joints, connective tissues, so your tendons, your muscles, your bones, and as part of our management of patients we use immune modulating drugs, and these are to help stop the body from a self-destructive process which we see in most of the rheumatic conditions.
So what does a typical day look like for a rheumatologist?
Rheumatology is a lovely specialty, so it's mainly outpatient based. So we mainly do clinics. So typically you start your day in the clinic, and this varies from person to person. If you're in the state, it's usually 8 o'clock. You start your clinics. If you're in private, you can decide what time you want to start. So I generally start my clinics at 9 o'clock.
Would this be a clinic?
Yes, this is a clinic, yes. So I start my clinic at 9 o'clock, and I see patients, mainly outpatients. So you've got patients that are electively booked. They walk in and you see them and they follow up as outpatients. And sometimes you may have to see patients in the ward, so either your own admitted patients or other discipline or other colleagues can ask you to see their patients in the ward, so you go and see your patients. This you can do either first thing in the morning or at the end of your day.
You do both every day?
If you have to see someone in the hospital, but the main thing is outpatients, clinics. And also with rheumatology comes a lot of administrative work. So you find after hours or before your day starts, you have to do your admin. And trust me, it's a lot.
So what is the work-life balance like in rheumatology?
I think it's great, and it's one of the reasons I've chosen to become a rheumatologist. Like I said, it's outpatient based, so you've got stable patients who are booked, who come out to the clinic, and then you have few patients who may need admissions. Some come in for day infusions of their treatments, of their biologic drugs, and I really have to have my phone ringing in the middle of the night to come and see a patient in hospital or to resuscitate someone. You know, we let the intensivists or the casualty officers do that. So it's really a lovely specialty, and it's a Monday to Friday job.
So your weekends are free?
My weekends are free.
At least. So what is the bread and butter of rheumatology in South Africa, and can you give us a brief overview of these conditions? So
our bread and butter is basically, the commonest thing is rheumatoid arthritis. That's the bulk of the patients, and these you mainly see in the state hospital. In the private sector, you notice that our rheumatoid arthritis patients are not as many, and I think it's because the general practitioners, the general physicians are managing these patients. The few that trickle our way are the complicated rheumatoid arthritis patients. So I actually have a very few rheumatoid arthritis patients in our practice. The big bulk of patients we see also is systemic lupus erythematosis, and we've got a lot of patients with spondyloarthritis. And there is also some other, and gout is a common group of patients we see. And then you've got, from time to time, you'll see patients with scleroderma, patients with inflammatory myositis, patients with vasculitis, but they are not as many.
Okay. If one wanted to specialize in rheumatology, how does one go about it?
So, rheumatology is a sub-specialty in internal medicine. So, for someone who's finishing off or who's just completed matric, the journey will be after matric, you're going to medical school to do your undergraduate training. After that, you do your 2 years of internship. After internship, you do a year of community service. After community service, then you apply for the registrar post in internal medicine. And the posts are not many, so you may have to wait 2-3 years.
How many posts do you think there are?
In internal medicine?
Yeah.
Off the top of my head, I'm sure there are about 100, 150 maybe on the Wits circuit. So each academic hospital has a certain number of posts and they can train a certain number of people. Once you make your way into a registrar post, if you're lucky, then you train for 4 years to become a physician. And after that, you then apply again for a subspecialist post in rheumatology. And then you go into training. And yes, that is the path that one has to follow to become a rheumatologist.
Wow, that's actually so amazing that you went through all of that. Wow. What is it about rheumatology that drew you to the specialty?
I think the main thing was the work-life balance. Like I said, I've got my weekends. My weekends are free.
Yeah.
It's only an odd weekend where you have a patient or two in hospital. But most of the times you find the intensivists will look after your patients if they're in ICU, or the physicians will look after the patients. So generally you've got your weekends free. After hours you are free, you don't have to come into hospital. So for me that was very attractive.
Mm-hmm.
And it gave me the opportunity to be a mom, to be a wife.
Which other specialities do rheumatologists work closely with in terms of the multidisciplinary approach?
So, rheumatology is a multi-systemic discipline. So most of our conditions affect every part of the human body. If you take lupus, for example, you've got CNS involvement, so you work with a neurologist. You've got eye involvement, you work with an ophthalmologist. You can have lung and heart manifestations, so you work with a pulmonologist, the cardiologist. You've got skin manifestation, you work with a dermatologist. You've got neuropsychiatric features, you work with a psychiatrist. You've got kidney involvement, you work with a nephrologist. You need to do imaging for most of your patients, you work with a radiologist. You need to get tissue diagnosis, you work with the pathologist. You need to rehabilitate your patients, you work with the physiotherapists, the OT. So it's
really
one specialty where you work with everyone. And most of our patients come from different specialties. Even the surgeons refer their patients. For example, you get patients who present with inflammatory bowel disease and they've had scopes done by surgeons and they get referred to us.
How does one confirm the diagnosis of sero-negative rheumatoid arthritis?
So, sero-negative rheumatoid arthritis is basically a diagnosis of exclusion. Okay. So the typical seropositive, maybe let's start with the seropositive. They are seropositive because they've got their antibodies being positive, namely ACCP and rheumatoid factor are positive, with inflammatory arthritis. That is a clinical picture in keeping with rheumatoid arthritis, and it's usually a symmetrical inflammatory arthritis. And then you have a patient presenting with an inflammatory arthritis. Could be oligo or polyarthritis, but their rheumatoid factor and ACCP are negative, and then they get labeled as sero-negative.
During the COVID-19 pandemic, have you seen a rise in those with autoimmune diseases having a higher susceptibility to contracting the virus?
So I should make a disclaimer. I've not been in the front line for COVID treatment and management of patients, but from the patients that then present to the clinic, most of the patients, they did contract COVID-19, but they recovered. Okay, so from my experience and the conversations I've had with my patients, they seem to be doing well. They are getting infected, but they are doing well. And it could be because they're already on immunosuppressing drugs, which are being used to manage COVID. And maybe that is why they are not mounting such a robust immune response when they get COVID, and hence the good outcomes among our patients. So generally the outcomes from my practice, they have been good.
Just the last question. Who is susceptible of systemic lupus erythematosis in the population, and what are the red flags to look out for?
So systemic lupus erythematosis is a multi-systemic autoimmune disease, and it's mainly affects females, young females of reproductive age. And you find that the black females, Asian females are more at risk, and they tend to have more severe disease than the Caucasian females. You'll find that maybe for each female, for 10 females who have the disease, maybe one male gets the disease.
Sure.
So it's predominantly a female disease. And the red flags is a young patient, black or Caucasian, with antibodies that are positive and with organ involvement. So by organ, it's the brain, lungs, and the kidney especially. So the kidney is one organ that lupus loves and is associated with poor outcomes. So patients might end up on dialysis with end-stage renal failure, or might actually end up dying.
Okay, that's interesting. Thank you. Thank you so much, Dr. Ziki, for agreeing to do this interview with us. I really learned a lot from this, and it was honestly so interesting. And I'm sure everyone who also watches this video will gain a much deeper insight into what rheumatology is. It was so good to speak to you. Thank you so much.
It's a pleasure, and thank you for giving me the opportunity to share information on this interesting specialty. And it will be nice to have more junior doctors following a career path that leads to rheumatology.
Thank you so much, guys, for watching this week's video. Please like, comment and subscribe, and leave a comment down below which specialty you want to see next.
Hey guys, so an interesting medical fact is that your brain actually has enough memory to store the whole internet. So next time when you say, I should Google it, actually what you should be saying is, I need to think about it.